Hey everyone, welcome back to ICU Simplified. I'm Mask Medico and today's case will stop you in your tracks. Not all shocks are created equal. Some hide in plain sight, behind a chest injury, an echo finding, or a misdiagnosis. This is obstructive shock, sudden, deadly, and often overlooked. Stay with me. Real imaging, clinical signs, and three killers you need to catch before it's too late. He was just 28, a victim of high-speed road traffic accident. Breathless, hypotensive, trachea shifted, no breath sounds on one side. And within minutes, he coded. This wasn't a heart attack. It was obstructive shock. The kind that doesn't wait for labs or scans. You either catch it fast or lose the patient. Obstructive shock isn't about weak heart, muscles, or infections. It's about a mechanical block. Something physically preventing blood from returning to or leaving the heart. The heart wants to pump, but the circulation is jammed. And unless you fix that block, no amount of fluid or vasopressors will help. In this video, we will break down the three deadly causes of obstructive shock. That's tension pneumothorax, cardiac tamponade, and massive pulmonary embolism. How to recognize each one in seconds and how to reverse them before it's too late. Cause 1. Tension pneumothorax. When trapped air crushes the heart from the outside. So what happens that air had entered the pleural space and could not escape. With each breath, the pressure kept building. The lung collapsed, the mediastinum shifted, and the heart got crushed. All this resulted in hypotension, tachycardia, distension of neck veins, and cyanosis. These are the classical signs of a tension pneumothorax. Diagnosis: tension pneumothorax. No time to wait, no time to confirm. A needle, a hiss, and just like that, he started breathing again. Tension pneumothorax. Air enters the pleural space but can't escape. Pressure builds. The lung collapses. The heart gets compressed. Blood flow drops and shock sets in. The diagnosis is clinical. Don't wait for an X-ray. Needle decompression first, chest tube next. Quick check. You're the doctor in the ER. A patient is hypotensive. Breath sounds are absent on one side. What's your next step? A. Order a chest X-ray. B. Start vasopressors. C. Perform needle decompression. D. Get a CT chest done. Drop your answers in the comments below. Cause number 2. Cardiac tamponade. Fluid builds up in the pericardial space, compressing the heart from the outside. It can't expand, it can't pump, and if you don't act fast, it flatlines. At first glance, he looked fine. The blood pressure borderline, heart rate fast, neck veins distended, heart sounds muffled. Then came the restlessness, confusion, until minutes later, full-blown cardiac arrest. It was cardiac tamponade. Cardiac tamponade. Fluid rapidly fills the pericardial space. The heart struggles to expand. Diastolic filling plummets. Stroke volume crashes and shock sets in. We diagnose it clinically with the support from POCUS, and when confirmed, we don't wait. The treatment is clear: pericardiocentesis. A 35-year-old trauma patient is hypotensive, suddenly, with distended neck veins and muffled heart sounds. What's the next best step in management? Is it A. Give IV fluids. B. Order a chest X-ray. C. Perform pericardiocentesis. D. Intubate immediately. Let us know your answer in the comments below. Cause number 3. Massive pulmonary embolism. A large clot travels to the lungs and lodges right at the bifurcation. It blocks blood flow to the left heart. And just like that, the heart's preload collapses. This is a classical saddle embolus, and in critically ill patients, it can strike fast. Recognizing it early can be life-saving. He had just undergone a knee surgery. A day later, he collapsed. Sudden breathlessness, tachycardia, chest pain. His oxygen saturation dropped to 84% and his blood pressure began to crash. Within minutes, he coded, "This was a massive pulmonary embolism, fast, fatal, and tragically often missed." In massive pulmonary embolism, a large clot blocks the pulmonary artery. Blood can't reach the left heart. The right heart begins to strain and dilate. Cardiac output crashes and shock begins. Diagnosis: CT pulmonary angiogram, an echo showing right ventricular strain. Treatment: thrombolysis or surgical embolectomy in extreme cases. Here's your next case challenge. A young man collapses after knee surgery. He is breathless, tachycardic, and hypotensive. CT scan shows a large saddle embolus. What's the best next step? It is start IV antibiotics, give thrombolytics, start bronchodilators. D. Schedule surgery. Drop your answer in the comments. So let's recap what we have learned. Obstructive shock isn't always obvious, but when life's on the line, it demands speed and certainty. 3 deadly causes to never miss: tension pneumothorax, clinical diagnosis, needle first; cardiac tamponade, think of it when neck veins bulge; massive pulmonary embolism, silent but swift. The key is pattern recognition, prompt action, and trusting your clinical instinct. Because in ICU, every second counts. Thanks for watching. If this helped you, give it a like, share it with your colleagues, and hit subscribe for more real ICU stories. Stay sharp, stay fast, and always save lives. Don't forget to check out the full shock series. We have covered cardiogenic, septic, and more. That's all for today. Thank you, and bye bye.